Hi everyone. So welcome back to the second part of this new radiology webinar series, where over the next weeks to months we'll cover the approaches in common cases and the most common radiology imaging modalities you'll come across when you work in the hospital. My name's Kev Tang and I'm one of the trainees in South Yorkshire in the UK. If you missed last week's introduction to radiology, then don't worry, it will be uploaded to the Mind the Bleep website in the near future. So tonight I've got Dr. Kular, who's one of the radiology registrars in Sheffield, who will be teaching about CT head interpretation. So this will cover a logical approach, and we'll also discuss some cases as well. There is a chat box, so when there is some audience interaction, please feel free to be involved by typing in, and then Sam will be able to see what you've written. And please make sure you stay till the end, because then you'll get a link to fill in some feedback so you can collect that all-important certificate for your portfolios. And Sam, I'll hand over to you if that's right.
Yeah, great. Thanks, Kevin. I'm Sam. I'm one of the radiology trainees here in Sheffield in the UK. Today I've been asked to talk about CT head interpretation and just a bit about scanning and the modality itself. So just a brief outline of what we'll go through today. So we'll start off with just some outlines, some objectives that we're going to go through, some anatomy, some common conditions, a bit on head interpretation, go through some cases at the end, and then we'll have a brief touch on vetting and reporting. So by the end of the talk, hopefully, you'll be able to identify some anatomical landmarks on the CT head, describe some components of the meninges, the meningeal layers, describe some vascular territories that supply different areas of the brain, identify cerebrovascular events on a CT head, and differentiate between some of the features of hemorrhagic and ischemic stroke. So just some background. So head trauma is the leading cause of death in people under 30 years of age. So it's a very common cause of mortality. It's more common in males, 2 to 3 times more than females. And it may be related to some of these common factors, which are motor vehicle accidents and assault, 2 of the leading causes. And in the elderly, for those who have worked in the hospital setting, will already appreciate that a considerable number of elderly patients come through with falls and injuries to the head, requiring a CT head scan. So just some anatomy to start off with. So see, the anatomy of the brain and skull is composed on the outside of skull bones and underlying sutures, which join the bones together. They follow the pattern of the lobes, which are named similar to sutures and bone pattern that we will come on to in just a moment. And then below the skull layer, we have a dura mater layer. So the main bones that we can see here on the CT, on this CT reconstruction of a skull, we can see the frontal bone, which is at the front of the head. At the back, we have the occipital bone. We have a temporal bone on either side of our head, on the left and right. And at the top, we have 2 parietal bones, although we tend to refer to it as just the parietal bone as a single entity. And these bones are joined by various sutures, which are seen basically in the middle of these bone spaces. So we have a coronal suture, which joins the frontal bone to the parietal bone, a sagittal suture, which joins the left and right sides of the parietal bone, and then we have the lambdoid sutures, which join our occipital bone to the parietal bone. There's also a squamous suture, which adjoins the temporal bone to the parietal bone as well. And there are several others, but these are the major ones to start off with at a basic level. And then the brain, again, as probably most of us all know, so it has 3 main compartments, starting with a cerebrum, or alternatively known as a supratentorium, a brainstem, and a cerebellum, also otherwise known as an infratentorium. So these are subdivided into their respective sections. So the tentorium, it refers to the tentorium cerebelli, and this is just a side-on sort of sagittal view of the brain. And you can see there's a tentorium cerebelli, which would divide our brain parenchyma from the cerebellum, i.e. the supratentorial above the tentorium and infratentorium below the tentorium. And then we have the brainstem, which is composed of three major structures, which is the midbrain, the pons, and the medulla. And then the lobes of the brain. So the lobes of the brain are again named after the bones that overlie them. So at the front, we have the frontal lobe, then we have the parietal lobe more posteriorly, then we have our temporal lobe sort of infralaterally, and at the back we have our occipital lobes. And as a broad statement, we all know the brain is more complex than this in reality, but generally the frontal lobe is associated with personality characteristically, the parietal lobe with sensory motor, so our sensation and our motor function, the temporal lobes with speech and memory, and the occipital lobe with vision. And obviously there is a lot more complexity, but that's again a good basic understanding of what the function of these separate lobes are. And then we have our brainstem, as we briefly mentioned, composed of our midbrain at the top, our pons, which is the bulkier aspect in the middle, and then our medulla. And each of these layers, essentially the brainstem itself as a whole, is our origin point for our cranial nerves. So it's where the cranial nerves exit and go to their respective areas where they have their function. So cranial nerves 3 and 4 will exit the midbrain and go towards the eye, where they have their various functions on movement of the eye muscles. The pons, cranial nerves 5 to 8, and the medulla, cranial nerves 9 to 12, as well as the respiratory and swallow centers. So we have the meningeal layers, which we have starting from the skin at the very outside aspect, and then we have the brain on the innermost aspect. In between that, we have various layers, starting off with the skull. And the skull is composed of 3 different layers in itself, and that they are the outer table and the inner table, which are two aspects of essentially a cancellous bone. And then we have a spongy layer in the middle, which is known as the diploic space. Below that, we have our dura mater, which is in the blue. And this is actually 2 separate layers of dura mater. So often we learn that dura mater is one layer, but actually there's 2 sort of sub layers. One is known as periosteal outer layer, and one's an inner meningeal layer. And they compose our dura mater. Below that, we have our arachnoid matter in the grey. And these also have little outpouchings, which we can see here, which can intrude into the dural space, and these are known as arachnoid granulations. And these are important because when we see these on a CT head scan, sometimes they can mimic small areas of thrombus, but actually sometimes these are all they are is just little arachnoid granulations. So it's important not to mistake these pathology. And then below that, we have our pia mater. So pia mater is the innermost layer of just overlying the brain parenchyma. And as you can see, the difference here is that it's able to follow the sulci of the brain as well. So it's the only layer that follows the invaginations of the brain. So we can see it scalloping along the sulcal pattern. And it's the only layer that does that, as opposed to the more flat outer layers. Now just coming on to some vascular anatomy. So the diagram as a whole, this is representing our circle of Willis. So a circle of Willis is essentially composing of an anterior circulation, which is supplied from our carotid arteries. So these are the 2 large arteries on the right and left side, which supply predominantly our anterior circulation towards the front of the brain, and our posterior circulation, which is from the basilar artery, which supplies predominantly the brainstem, the cerebellum, and the back of the brain, so the occipital lobes. And the basilar artery at the back is composed of 2 vertebral arteries, which aren't shown on this diagram, but they fuse together to form the basilar artery at the back. They give off small perforating arteries to the pons and the brainstem, and they have various arteries to the cerebellum and end as two dividing posterior cerebral arteries, which go on to supply both the occipital lobes. At the front of the brain, we have the two carotid arteries on the right and left side, which divide predominantly to give our anterior cerebral artery, which goes towards the front of the brain, supplying the frontal lobes, and the middle cerebral arteries, which are the biggest branches of our internal carotid arteries, and they supply predominantly the temporal lobes and the lateral aspects of the frontal and parietal lobes. So the largest territory supplied predominantly by the middle cerebral artery. And we also have an ophthalmic artery branch, which comes off just before the bifurcation of the anterior and middle cerebral arteries. And then we also have a connection between our anterior circulation and posterior circulation, which is known as the posterior communicating artery. And this is what makes it the circle of Willis, essentially. Without the posterior communicating artery, there would be no continuity of flow. And these are all interrelated, therefore, because of this communication with the anterior circulation with the posterior circulation. And these all, as we've mentioned, supply the various vascular territories. So you can see the anterior cerebral artery supplying the front of the brain and the paramedian sulci, the middle cerebral artery, large lateral aspects of the frontal and parietal lobes, as well as the temporal lobe, and then the occipital lobes are supplied by the posterior cerebral arteries. So just some basics on CT scanning. So CT scanning, first thing to remember when CT scanning is performed is that the patient's lying down and we're looking at the patient head to toe. So the patient's left is actually our right on the screen. And so everything is reversed. So what we see as an image on the right side of our screen is actually the patient's left side. And similarly, what we see on our right side of the screen will be the patient's left side and vice versa. So an image on CT used to be acquired on image, as you can see in A, where there would be a single detector placed behind the patient and an X-ray beam would be fired through the patient's head at the area that needs to be imaged, and then essentially the detector and the X-ray beam would move one by one around the head, and this could take up to an hour in the old days. Nowadays we have what's seen as D, which you may have seen scanners within our radiology departments, where there is a single ring of detectors and the X-ray beam can just move in one swift motion around, and because the detectors are already there around the patient, an image can be acquired in a matter of seconds, whereas it used to be a lot longer. We also tend to acquire the X-ray in a perpendicular plane to the orbits. So this is different to an MRI scan, where we can scan directly across the brain at right angles. We tend to do this because we want to try and avoid radiation dose to the eyes, as the eyes are very sensitive to radiation. And the main complication from radiation to the eyes is cataracts. So we try to avoid the eyes in our scanning, and therefore we try and scan at this angle. And therefore the brain may not appear the same on CT or MRI because of the way that they've been scanned. And that's why there can be some differences in the appearances, despite it being the same patient's head. So CT is based on Hamsfield Scale, and this is the unit measurement that we use to essentially assess a CT scan. So what we have is a Hamsfield scale. So a Hamsfield scale is essentially how much an X-ray beam can absorb into a tissue. So our densest tissues, for example, our bones, absorb lots of X-ray tissue. So it has a very high number into the thousands of this arbitrary scale. Whereas air, where X-rays can pass straight through and they don't get absorbed by any part of the body, have very low number in -1,000. And everything else in between has varying amounts of absorption. So soft tissue, water and fat. And in fact, we tend to say that water is the level of 0, so it's in the middle. So something bright, such as bone, will appear very bright because it's absorbed a lot of X-ray, whereas something like air, because it's not absorbing any X-ray, just appears black because there's no X-ray material that's been absorbed. Everything else is in between and somewhere a shade of grey in the middle. Now, because our eyes can only see approximately 50 shades of grayscale at one point, we have to narrow our window to only 50 shades or so. So when we put it on a soft tissue window, you can see here, this is a standard brain CT scan. We've put it on a soft tissue so we can see the grey and white matter quite nicely, but what we see above that is basically everything above this orange line becomes white, the bone, and everything below becomes black. So everything from water to air is black. So the lateral ventricles, which are here, containing our CSF fluid, becomes black. If we then want to view the bone, for example, we have to shift our scale up to that level, and that's what we call a bone window. The problem with that is that whilst we see the bone nice and clearly now, everything below that now becomes blacked out because it's below the line. And it's the same thing if we were looking at a CT of the lungs, we would shift this scale down to the bottom where they had the air window, and it would black out all the soft tissue, but we'd see the lungs very nicely. And so we shift these scales dynamically as we're looking through the scans to look at the various aspects of the tissue and the bone separately to assess the whole head entity. So in the UK, we have various indications for a CT. And those of you who've worked in the hospitals will be very aware of these guidelines by NICE, which are the governing body, have made it quite clear of which scans can indicate a CT, which patients presenting with certain symptoms can indicate a CT head scan. And they include dropping in GCS, suspected skull fractures, base of skull fractures, focal neurology, multiple episodes of vomiting. And these all will indicate a CT head that should be performed within an hour. If the patient presents with other sort of non-urgent symptoms, such as if they are on warfarin and they've had a fall but are otherwise well, or they've had a history of bleeding or clotting disorders, or they've had some amnesia, then they still indicate a CT head, but that's not as urgent. And they can have that within 8 hours, we say, but it doesn't need to be done within the hour, which the indications on the left require the CT to be done and reported within an hour, whereas the indications on the right could potentially wait till 8 hours, although we like to get them done, of course, as soon as possible. So on a CT head scan, we can see various structures, which will just cover some basic anatomy again. So when we see a CT scan, so again, the right-hand side of the image is the patient's left, and the left-hand side of the image is the patient's right. Because the patient's lying down, the bottom of the image is the back of the patient's head, and they're facing up, so the top of the image is the patient's front of the head. So we have our frontal lobes at the top of the image, occipital lobes at the bottom, and then we have our various structures. So these dark areas here, symmetrically seen on both sides, are our lateral ventricles. And these can be divided into frontal horns and occipital horns at the back. These contain our cerebrospinal fluid. The other ventricles within the brain are the third ventricle and fourth ventricle, which are seen on different slices, which we're not covering. Then we have various aspects. Again, it might be difficult to see, but this is actually a structure which sits adjacent to the frontal horn of the lateral ventricle, known as a caudate nucleus. And this is part of the deep grey matter. Adjacent to that, we have, again, this is very hard unless you've seen a lot of CT scans to necessarily see this very clearly. It takes a lot of time, but there's a slight bit of difference in the shade of grey here, slightly darker, and this is known as the internal capsule, which has an anterior limb, and it comes round. And if you correlate it with the anatomy textbooks, you'll see there's an internal capsule which has an anterior limb coming round to a genou, where there's a bend, and it comes down round to a posterior limb of the internal capsule. Often one mistake that's easily interpreted as potential hemorrhage or blood on a CT scan is these bright areas here. Now, these are just normal calcified choroid plexus, and these are often mistaken for bits of blood within the ventricles, but actually these are just normal physiological structures that produce CSF within the lateral ventricular system. and are just normal physiological structures and don't need any further management. But these can often be interpreted wrongly as hemorrhage, which they shouldn't be. Then coming on to stomatral pathology on the head. So blood on the head can be appearing differently depending on how old it is. So acute blood is bright on a CT head. So we see it as a hyperdense structure because it's more dense than the adjacent brain. After approximately a week, it becomes the same density as the brain. So you can see it gets very hard to differentiate a line between the brain and the blood. And that's when we call it isodense. And that can be sometimes the most difficult scan to try and see. But if there's not very much blood, you might not see very much. So it's very difficult to sometimes see these. So you have to look for the other signs like mass effect and any changes to the sulcal pattern to detect these. And then after approximately 2 or more weeks, the blood becomes low density or hypodense. And so it's a lot lower or darker than the adjacent brain. And therefore you can see that these are now chronic, and these are not active bleeding, but they have matured and now are chronic. And it's hard to say whether these are 2 weeks old. Some patients will walk around with these for years and not realize if they're not causing any significant problems. So we don't know how old these may be if they're just low density. The only difference is that very hyperacute blood can appear dark because it's fluid density. So if there's very hyperacute before it's clotted, it will appear the same density as fluid like CSF because it hasn't clotted yet. It's only when it clots it appears bright. And then coming on to some trauma. So trauma that we can see on a CT scan can be either from primary trauma, so this is what we see initially. So if somebody had an injury directly to their head and were hit on the head, for example, the injuries that we'd see on a CT at that particular time would be injuries to the scalp, fractures to the skull, and any intracranial bleeding. If later on in a couple of hours time, we'd see secondary effects. So we may see other effects after, for example, hypoxic ischemic injury, swelling or edema. So that doesn't necessarily occur straight away. So it's only a few hours later that we may see that, which then causes raised intracranial pressure. If there are open skull fractures, for example, there may be secondary infection and meningitis or abscesses, which we may not see till later on, but it's important to be aware of these. The Monro-Kelly doctrine is essentially the principle within the brain that the brain is a box, basically containing 3 major components of brain tissue, CSF, and blood, all contained within a fixed structure, which is your skull. And these 3 have to have a balance. And normal people have a balance of all 3, predominantly with brain, with a bit of CSF, bit of blood. If there is acute bleeding, then it means the blood will increase, but that there is a limited space. So the other 2 components have to compensate or give way for that blood. So that means that the brain tissue will be compressed if there's more blood. Similarly, if there's hydrocephalus or buildup of CSF on the brain, that can cause the brain tissue to be squashed. Or if we have brain tumors or brain swelling, we can compress blood and CSF, which means that we might get compression of vessels and leads to stroke. So essentially, this is the principle where neurosurgeons work, where if there is an acute bleed, they decompress the skull, and that allows the blood to be able to evacuate the fixed space, and it allows the brain to be able to decompress into that space that is relatively fixed. So coming back to our meningeal layers that we addressed earlier. So we're going to come on to some types of bleeding now. Okay, so the first type of bleeding is between the skull and the dura mater and the outer periosteal dura mater. And this is extradural hemorrhage. So this is often seen as a convex structure or lentiform structure. and it's basically because of the way it's just beneath the bone, it adheres to the suture lines that the bones are fused at. So it will adhere to the sagittal suture, so it won't pass from right to left, because the sagittal suture, if you remember back to our initial diagram, we had the sagittal suture running across the brain, separating into right and left parietal compartments. So it tends to stay on one side. It tends to not be able to cross the front because of our coronal suture, and it will also be prevented from going to the back of the brain by the lambdoid sutures. So we can see that on this diagram, where we have blood acutely in an extradural space because it's nice and convex or in a lentiform shape. And then we have our position of our coronal sutures, which would be coming across the front of the brain, preventing this area of blood crossing into this frontal space. Then we have at the back, we have blood in two spaces here. So these are two separate areas of bleeding, but they're essentially prevented from crossing into one another's space by this fusion of suture here, which is our lambdoid suture, which we also see on the other side. And then this area of blood is prevented from crossing to the right side by the sagittal suture across the midline. So this is how we can tell it's an extradural hemorrhage. This is different to subdural hemorrhage, which is between our dura mater and our arachnoid mater, between the blue and the grey spaces. So this often appears as a more concave shape or lentiform shape, or concave shape or crescent shape. And this has a different mechanism of separation to the sutures which we see in extradural hemorrhage. So in subdural hemorrhage, the prevention across is performed by the dural layers. Our two main dural layers in the brain are our falx cerebri and our tentorium cerebelli. So our falx cerebri runs across the midline and it divides our right and left hemispheres. So when blood generally tends to accumulate, you'll see it coming across in a subdural location. It will be crescent shaped, but then it won't be able to cross the midline. It may go into the midline space, it may start to collect along the midline, but it won't cross over into the other side. Similarly, the tentorium cerebelli will mean that if you have subdural hemorrhage in the supratentorial layer, it generally won't cross into the infratentorial layer. Or vice versa, you may have blood around the cerebellum, but it generally then won't cross into the brain parenchyma above it because of the tentorial layer. We then can go down a further space to come onto our subarachnoid space. So as we saw earlier, this is between the arachnoid space and the pial layer. So because the pial layer is able to go into the invaginations or sulcal layers of our brain, so can the blood when we have an acute bleed in the subarachnoid space. So we tend to get this picture of a more sulcal pattern of bleeding, which is dispersed throughout the brain invaginations in a more sulcal and gyral pattern than we see in a subdural or extradural, which tends to stay on the outside. These can go into our small fissures within the brain a lot easier. The main two methods of subarachnoid hemorrhage, most commonly, so we have trauma, but the other very common mechanism of subarachnoid hemorrhage is aneurysm rupture, which we can see in the brain quite commonly as well. Often we can tell what the aneurysm, where it's originating from where the blood pools. So it tends to be most commonly the anterior communicating arteries, so connecting the two anterior cerebral arteries, the posterior communicating artery, which we saw on our circle of Willis diagram, and the basilar artery tip, which is also another place for aneurysms to commonly develop. So just a brief summary. We have our extradural lens-like hemorrhage, our more crescent-shaped, concave, subdural hemorrhage, our more subarachnoid invaginating hemorrhage. And we also can get actual injury to the brain itself if the brain has intraparenchymal or intracranial bleeding, where we will see more of a circular pattern of injury or contusion directly to the brain. So it will appear much more focal, and essentially it's almost like a bruise of that area of the brain. Now, ischemic stroke. So ischemic stroke we'll just briefly cover. So when we have ischemic stroke, it tends to follow an arterial territory. So this is an example of an anterior cerebral artery infarct. So we saw on the diagram earlier where we saw where the anterior cerebral artery circulation is supplying. It supplies the anterior aspects, and it follows closely with the paramedian space. We tend to see, compared with the normal right side of the patient, we have nice sulci here. The sulci are effaced due to the cortical swelling. We have loss of grey-white matter differentiation. So the grey and white matter are separated. And I've zoomed in on a picture here where we can see the central white matter is a darker grey than the outer grey matter. And the white matter is essentially our transmitting fibers. Grey matter is essentially our initiating fibers that we use to initiate a particular action, and the white matter then transports those fibers. And we lose that differentiation here due to the edema from infarction. And also, because they conform to an arterial territory, we tend to get a typical wedge shape of infarction because it's a territory. So basically the middle cerebral artery won't be involved, the posterior cerebral artery won't be involved, so it quite nicely adheres to that. Sometimes you can get multiple arteries being affected, and you might have the anterior and middle cerebral arteries had thrombus or stroke, then you may get a larger area, but you can generally tell what area of stroke has been affected given the arterial distribution. Skull fractures. So with skull fractures, we have depressed skull fractures, or we have normal skull fractures. So the depressed skull fractures, we can see, because the outer table is quite a heavy structure, you may just get, in a quite severe skull fracture, you may get depression of the skull, which may then interfere with the sinuses running around the outside of the skull. One common pitfall, again, with skull fractures is how do I tell the difference between a skull fracture and a suture? The sutures tend to be symmetrical on both sides, so you can see this picture here. So we can see sutures on both sides, and we know the expected locations of our coronal sutures and our lambdoid sutures now. There are many other sutures as well within the skull, but generally you'll see symmetry on both sides. Sometimes we can see asymmetry of the sutures. So if we have a fracture that goes through the suture, it can sometimes widen the suture on one side. So here on this bottom picture, you can see that there's widening of the left side of the lambdoid suture compared to the normal right side. And that's because a fracture is passing through that skull suture. And therefore we call this diastasis, or widening of the suture. And it's particularly common in the lambdoid suture where we have occipital bone fractures. So some important features now of interpretation. So the major things that we want to cover when we're looking at heads are mass effect or midline shift and hydrocephalus. So mass effect, we have when we have blood or any structure such as a mass lesion that may cause the brain to be shifted. And so the key problem with that is that we can see on the diagram on the right is that we have herniation of the brain. And herniation of the brain in various directions can occur. So we can get herniation of the brain across from right to left, which is known as subfalcine. So this, because we know the falx cerebri is running down the middle, this is subfalcine, so it's beneath the falx cerebri. And this is going from left to right or right to left. Similarly, if we can have transcalvarial, so it's calvarial skull, so through the skull, we can get transtentorial, so the tentorium cerebelli, below the tentorium if we have enough mass effect. And so these are the key things to look out for, because if we squash the brain parenchyma, it can lead to compression of the brain stem, and the brain stem is important for our respiratory center. And if we can't have a respiratory center, we can't breathe, and therefore we will essentially have a fatality from that. So it's important to look for any features of mass effect in what we call coning, which is where the cerebellum and cerebellar tonsils and brainstem start to descend into the spinal canal. Then the second major aspect to look out for is hydrocephalus, which is the buildup of CSF fluid, again, within the lateral ventricular system. And this, again, going back to Monroe-Kelly doctrine, this can, well, any increase in either blood or fluid, this is, in this case, it's fluid, will increase the amount, or decrease the amount of space available for the brain, and therefore it will cause further deterioration, further impact on the vessels, may lead to further impact in ischemic stroke, may lead to further impacts on cognitive function and mass effect, which can lead to then herniation. So systemic approaches to interpreting CT head. So there are two, or I've listed two methods here, and these are two of many. So one method can be an outside to inside approach, so starting at the skull, going into the dura next, then going to the brain, and then assessing the ventricles, the basal cisterns, and then the soft tissues. A different method, if you like acronyms or abbreviations, you can try blood, can be very bad. So you can start looking for any blood, so look for any bright, hyperdense fluid within the brain. Then you can look at the cisterns. Then we look at the brain itself, so looking for any grey-white matter differentiation loss or any mass lesions. Then we can look at the ventricles, is there any hydrocephalus? Then we can look at the bones, is there any fracture, or are there any lesions of the bone? So for those who may be undergoing any exams, this is a quick OSCE style station. So what you'd want to do is you would confirm any patient details, presenting an image. So you would say this is a CT head axial scan. So these images are taken in axial plane, so it's looking at the head down of the various patients. And then you're going to comment on the obvious abnormality. So you would say, in this case, the obvious, as we looked at this one earlier, an area of hypoattenuation in the left frontal lobe with mass effect compression of the left lateral ventricle. That's just for exams. So I'm just going to have some cases now. Okay, so I'm just going to scroll through a few cases, and if anyone wants to type in what they think on the chat box, then feel free to do so, and I'll see if you can beat me to it. I'll give you a few seconds, and then if not, I'll just present the answers. So this is a case of a patient with 2 days history of a left homonymous hemianopia. So I'm just going to scroll through the CT scan, and if we have any answers, we can just type them in to the box. So I'll just go through the image a few times and see what, if anything, can be seen. So what I would be thinking if I saw a history of 2 days of left homonymous hemianopia, so we can tell a lot from this history already. So 2 days means that the patient has had symptoms for not just a very acute period of time, it's a reasonable amount of time. So any changes that may have occurred would be more obvious now after 2 days than they would be if they had it for 2 hours. The left side, so a good history, can be very useful to identify the side, because it means that, knowing the brain, we interrogate the opposite side generally because of the way that the tract fibers tend to be orientated on the opposite side. So now left homonymous hemianopia, So it's visual symptoms. So we're now going to be localizing our attention onto the right side and the visual cortex in the occipital lobe. And we know it's 2 days old, so we think that changes are going to be quite established at this point. So we can direct our attention here straight away to the right occipital lobe, where we can see, if we read on this image, a nice sulcal pattern on the left side. And you can see the nice fissure. On the right, there's this area of low density. It's cortical swelling, loss of sulci, loss of grey-white matter differentiation. It's in a quite well-defined region, and so this is consistent with a right-sided posterior cerebral artery territory infarct, and it would fit with the clinical symptoms. Other changes that we can see, so we can see an area of low density here at the top of the brain. So this is just something that we see very commonly in people, patients who are particularly older. And this is something that we can just say that is small vessel disease or chronic small vessel ischemia. And this is just a long-standing, essentially, it's like atherosclerosis of the peripheral vascular system. So over time, particularly patients who've got vascular disease will have these low density changes, and they tend to be within the white matter. They don't resemble a stroke because they don't have loss of grey-white differentiation. There's no cortical swelling. There's no wedge-shaped pattern. And therefore, and it's only involving the white matter. So it's very consistent with small vessel disease rather than an acute stroke, which we can see goes all the way to the cortex. The next one, so we have elderly, confused, increasing falls. So we come through this image again. So if anyone has any ideas, feel free to type them away. But otherwise, I'll scroll through them a few times and then go through the answers. So again, this is a very common presentation for this particular history and patient population. So immediately going through the head scan, we can see that there are some changes on both sides of the brain. So we can see that there are bilateral crescent shaped. It spans all the way across from front to back, bypassing the suture lines of the lambdoid and coronal sutures, but it does not bypass the midline of the falx. They are on both sides and they are of mixed density. The left side is larger and there's considerable mass effect with effacement of the sulci and compression of the brain. On the right is less so. And so these are consistent with bilateral subdural hematomas. The density is mixed. It's not quite bright. It's not quite dark. And so this patient may have had an acute on chronic subdural hematoma that's developed after maybe a recurrent fall. A lot of patients will often have chronic subdural collections long-term, but then it may be recurrent falls that they acutely bleed and make those collections larger that then cause them to go to hospital. But many patients can function if they have small subdural collections still. Okay, so the next one, we've got a case of decompression surgery previously for a left-sided subdural hematoma in the past. And again, I'll just scroll through these images. So you can see there's been a burr hole. Going back to the decompression that we said earlier, helps to evacuate that excess blood and allow the brain to expand out. And then immediately we can see on the right, there's this rather isodense, predominantly right-sided collection or hematoma that again, crescent shaped, does not cross the midline, but it does cross the coronal and lambdoid sutures. but there's also the lower down aspect, there's some higher density here. So we can see there's an acute on chronic subdural hematoma, or an acute on subacute hematoma. This is probably a subacute hematoma because it's isodense, it's similar density to the brain, so it's probably an acute on subacute. And the left side now is a chronic residual subdural hematoma because it's hypodense, or it's low density. So you've got almost all three phases of a subdural hematoma on this scan: in the acute phase, the subacute phase, and then the chronic phase on the left side. Okay, so the next case, left-sided inattention. So again, we've got a history. We're going to focus ourselves on to the right side because of the left-sided symptoms. So this scan, I'm just going to go up and down a few times. And for the eagle-eyed amongst you, you will see here, if I'm just freeze on this frame, if you compare the left side of the patient to their right, you'll notice that there is a dark region here that is seen within the right side of the patient's posterior parietal lobe, bordering on their occipital lobe. A loss of grey-white matter differentiation, as you can see nicely on the other side, the blend between the dark grey and the light grey. It's now all just dark grey. There's some sulcal effacement, so you lose some of the sulci. And again, this is consistent with an early infarct, and this is much earlier than the infarcts that we've seen previously, where they've been a lot darker, but this is more subtle. But again, we can see that this is an infarct given its wedge-shaped pattern and the various features that we've mentioned. So this is again in keeping with a right-sided posterior territory infarct. And then the next day, so this is evolution of the same infarct, we can see how that's changed and how much easier it is to be able to discern that infarct now, once there's been even a day. And that's why it's important to be able to pick up these changes early, to be able to establish IV therapy, or nowadays we can do endovascular procedures as well for certain cases to help remove those clots causing the stroke. Here is a case of sudden onset worst ever headache. So the history probably should give it away, but there's just a few slices that show this pattern of blood. This is quite central. There's a focal blob of blood here. As we come higher up, we can see the blood seeping into the various sulci of the brain. Now, given this distribution, as we mentioned earlier, this is where the anterior cerebral arteries would be passing through the frontal lobes. Connecting them would be an anterior communicating artery aneurysm. So we can do CT angiogram to assess for any underlying aneurysms, and what we can see here, where we can see our right and left anterior cerebral arteries. In between is this blob, small blob here, that is an aneurysm responsible for that subarachnoid hemorrhage. And often they can be very small, but they can be treated both in an endovascular approach or neurosurgical approach. So now going back to trauma again, cyclist hit by a car. So going through the images, so we can see immediately there is some blood on the left and also blood at the front on the right. And this patient has got all three distributions of hemorrhage on their scan. So they've got a lentiform looking extradural hematoma on the left side. At the front on the right, there is a right-sided subdural hematoma. And the blood doesn't always have to collect. If there's not enough of the blood, it won't necessarily go all the way around in a crescent shape. If it's just a small amount of blood, it may just start coming around like this and stop But then you'll also notice some further blood within the sulci of the brain as well, and that again is in keeping with subarachnoid blood. So often in cases of trauma, particularly here, you can see the sulci have got blood within them. In trauma cases, you may get multiple areas of bleeding just because the trauma has just rattled everything within the brain. So you'll get all the various patterns of bleeding. And then if we looked at the bone window, we would see that there is a skull fracture on the left side, contributing to that left-sided extradural hematoma. So this was a slightly different case. This is a patient with known lung cancer. So odd behavior, scrolling through this. A few slices here. So we can see that there is abnormality within both frontal lobes. And then we can see some areas of higher density which look like they are defined. You could almost draw a ring around them. And these are in keeping with metastases. So these are different to, well, the differential for this appearance could be potentially stroke, some could say, given that there's a lot of dark material around the outside of the brain, which is edema. This is a different type of edema to the edema that we see in stroke. In stroke, we tend to get what we call cytotoxic edema, which is where the edema will affect the grey matter as well as the white matter. Whereas this type of edema, which we tend to see in metastases or any inflammatory or infective processes, is called vasogenic edema. And this is an edema that essentially spares the grey matter and tends to only involve the white matter. And this is due to in ischemia, you get a different type of breakdown of the vascular walls, and therefore the edema can infiltrate the grey matter in a different way to what you would see in infection or cancer. And so you can see here that there's relative sparing of the outer grey matter where the edema is seen. So you tend to get this almost scalloping type of appearance, which is characteristic of vasogenic edema, and you tend to see these in either infection or neoplastic processes. And given the history of lung cancer, the differential for these could be that they could be abscesses. So if the patient had a history of a raised white cell count, a fever, these could be abscesses. And often we need to do an MRI sometimes to differentiate between the two. But given their lung cancer history and absence of any inflammatory marking, raised inflammatory markers, these are likely to represent lung metastases. The next patient, going back again to trauma, so it's the underlying theme, found on the floor, confused. So going through the head scan a few times, you can see there's bilateral subdural collections which appear chronic. So they're very low density, so they're dark. So we know that they've been present for a while, and there's no bright material to suggest acute hemorrhage within them. But what we do see is in the lateral ventricles, some acute high density material. And remember, the patient's lying down, so this is at the dependent aspect. So this will layer, and this is acute intraventricular hemorrhage. And sometimes in cases of low impact or velocity trauma, there can be just a small amount of intraventricular hemorrhage that just shows us a small amount that's confined to the ventricles, and you may not see it elsewhere. So it's important to always assess the ventricular system, not just for hydrocephalus, but in case of trauma for any potential blood as well. Next one, this patient that was punched. And so we see left-sided high density. It's scalloping in appearance, and it's going within the sulci of the brain. So comparing it to the previous subarachnoid hemorrhage, as this is a case of subarachnoid hemorrhage, this is more confined to one side. If there's a clear history of trauma, this is unlikely to be an aneurysm. So then we can leave it at that, and we don't need to do an underlying CT angiogram, which we may do for if we suspected an aneurysm, for example. But it's important, that's why it's important to get a clear history. So these are just, again, some spot examples. So again, there's an example of subarachnoid hemorrhage, which is quite central, invaginating the sulci on both sides. Another example of a crescent-shaped subdural, which is not only going across the side, but also you can see it coming across the falx at the back here. So it's prevented from going across to the left side by the falx cerebri, but the blood can still collect in the midline along the falx, but it just can't pass over it. And it's causing a considerable amount of mass effect, which is another thing that we need to remember to mention when we report from our radiology side. And again, this is another bit of bleeding. So we have, again, sulcal blood conforming to a subarachnoid pattern. But what we also have on the left side subtly is crescent-shaped, bit of high density in keeping with a subdural hematoma. So this is subdural and subarachnoid hemorrhage, I should say. On this particular image, so we have again a nice lens-shaped or convex-shaped hematoma. It's not passing the lambdoid sutures at the back or the coronal sutures at the front, and this is in keeping with an extradural hemorrhage. We have here a low-density chronic subdural hemorrhage with a mild amount of mass effect, so replacements, and again, this is all in keeping with chronic SDH. This type of injury is another common pattern that we see. So this can be where there's a left-sided extradural hematoma, as we're all very familiar with now. What we see on the right side is actually a small amount of round injury, and this is what we call contracoup injury. So this is where the brain, because it's in a fixed liquid box, it's able to float around the CSF. And so when we get an injury to the left side, the brain will slosh around in the CSF, and essentially it will get smashed against the opposite side of the skull. So we'll see an injury on the opposite side as the brain's been moved and rattled, and it's gone off to hit the other side of the skull with the impact. And so often we get this intraparenchymal, which is a nice round bit of blood within the brain tissue itself, where the brain's been injured by hitting the skull on the opposite side. Sometimes we may only see the contracoup injury. So the coupe injuries, if any of you are familiar with French, means on the same side as the impact. Contracoup means opposite side too. So sometimes the opposite side will be the only side of the injury, and the normal side of impact may be normal. So it's important to understand the mechanisms of injury to be able to work out where bleeding may occur from. This one is another case of an extradural hematoma, but what we see in the middle is a small amount of low density, and this was going back to our initial few slides where we mentioned that hyperacute blood can be low density. So low density can be similar to CSF, and therefore if we've got active bleeding, so if it's bleeding at the time of scanning, then we may see this small amount of low density within the high density. And this is just representative of an hyperacute extradural hematoma. Again, this is a nice case of bilateral extradural hematomas. Because there's been an injury to the front of the brain, we have bleeding in both compartments, but they are unable to cross each other because of the sagittal suture that runs in the midline. So we get this bifrontal convex appearance. We may get mixtures of subdurals, where we get acute blood in a chronic hematoma. So we'll have classical layering. Because active acute blood is more dense than watery old blood, then we'll have the deeper acute blood will appear lower or dependent, and you'll get this layering effect where you may see an acute on chronic hematoma. This is often a very tough case to detect, particularly if there's not much of it. So what we can see here is that there's almost no sulcal pattern on the left. there's a little bit of midline shift, but actually we can't see any definitive layer of blood. But what this is an isodense subdural hematoma, and the only way we can pick this up is by the secondary effects, by seeing the mass effect, by seeing the sulcal effacement. We can't actually see the differentiating line of blood because it's the same density as the brain. So often these are the hardest cases, if particularly there's not much mass effect or sulcal effacement. These can be the most difficult to detect. So just finishing off towards the end now, so just vetting and protocoling. So most scans we have in CT are non-contrast scans. So in most cases of trauma, hemorrhage or stroke, we'll be able to just do without contrast, look for the basic signs. Then we may go on to do MRI for further differentiation, particularly in cases of stroke. Some indications to do contrast we may use for tumours in the acute setting, infection to pick up any abscesses, any settings of vasculitis where we may see any vascular abnormalities. And as we've seen already with the aneurysms, we can use CT angiograms in the arterial phase where we put the contrast and scan when the contrast is running through the arteries to detect any aneurysms or any large vessel occlusions in cases of stroke, where we can see a clot blocking the vessel. And then we also look for venous sinus thrombosis. So is there a clot in the venous sinuses that we can also see on a CT venogram? So they would be the indications for contrast. But otherwise, most things we can see on a non-contrast plain CT of the head. And just sometimes looking at reports, so those of you who may be on the wards looking at reports, sometimes may get confused with the terminology that we use sometimes. And the problem is sometimes many things can mean the same thing. So some phrases such as chronic small vessel disease, which is essentially, like we've mentioned, it's almost like atherosclerosis of the peripheral vascular system. It can be described in a report as mature ischemic change. It could be chronic white matter ischemic change or disease, supratentorial white matter, small vessel ischemia, periventricular small vessel ischemic disease. But all these, a key thing is that they are not acute findings. They are just findings that are associated with aging or general background pathology, and they don't require any immediate actioning. If there is an acute stroke, they should or will be described as an acute stroke in the report. So if you see the word small vessel disease, small vessel ischemic disease, don't necessarily be worried by that. Look for the words acute, and that will be deciding whether it's an acute pathology or not. And also involutional change, again, that's referring to an age-appropriate, we see that in reports, an age-appropriate shrinking of the brain. So obviously as we get older, our brains will get slightly smaller with all of us, and it's not necessarily excessive for age. So everyone has an amount that's appropriate. If we see the word generalized cerebral atrophy, often that can be used interchangeably with involutional change. However, technically it shouldn't be, because atrophy implies pathological loss of brain parenchyma, but often reports will often mention generalized cerebral atrophy, but they're referring to a more appropriate age expected rate of parenchymal loss. And again, it's not anything to be particularly concerned about unless they specifically mention a disproportionate focal atrophy of a particular lobe or pattern of lobes, and that's when it may require further investigation. But generalized cerebral atrophy probably wouldn't require any further investigations. And again, if it's not reported on, it's likely not to be a significant finding. So not all reports will have findings mentioning the skull, for example, on a stroke CT head scan, but we will all have looked at the heads and the skulls completely. And so even if a report doesn't necessarily mention it, doesn't mean that it's not been looked at. It probably means that there's nothing necessarily acute on that finding or wrong or significantly pathological. So you don't need to worry about it. So in summary, we can use the CT head for evaluating patients with emergency head trauma quite efficiently. Early diagnosis will lead to better outcomes. And again, for those who are working on the wards, being able to recognise these quickly can help you to then just pick up the phone that bit quicker if we haven't reported the scan quite then. But if you've seen a bleed, you can pick up the phone to neurosurgery and get that patient referred earlier, and then they can have potentially any management performed earlier as well, which would be only a good thing. Remember to look for any associated fractures on the bone window. look for any complications of edema, midline shift, herniation, and also we can see the different ages of blood products with subacute or chronic presentation. And if nothing else, remember extradurals look like lemons and subdurals look like bananas. Okay, so that's the end of my presentation. Thank you very much. And any questions, I'll hang around for.
Thank you very much for that, Sam. That was fantastic. I learned quite a lot this evening that I'll apply when I go on to my next shift. There are lots of things popping up in the chat. There's a couple of questions. I'll let you answer those first, if that's all right.
I can't actually see any questions, annoyingly, but
I can read some out to you. So one has asked, how do you differentiate between interventricular calcification and hemorrhage?
okay, yeah. So calcification, so it all goes down to our Hamsfield units scale. So calcification typically is similar to bone. Calcium is obviously, bone is made of calcium. So calcium will be very, very bright. And what we can use on CT is we can use tools to measure the Hamsfield units of anything that we see. So we would be able to put a little marker on, it would tell us a Hamsfield unit. And so calcification would be very bright, so in the thousands. Blood would be similar to soft tissue, so it would be somewhere around 50 to 70. So we can objectively tell.
Fantastic. And there's another question. So when requesting a CT, do we specifically need to ask for contrast or non-contrast depending on indication, or would this be chosen by the radiologists?
Mm-hmm. So generally the radiologist will choose protocol it appropriately. On some occasions it may be useful to be able to suggest it, and not all radiologists will be familiar with neuroimaging, so they may not necessarily think about doing the extra contrast scan, particularly if they haven't necessarily done much neuroimaging, if they do other parts of the body, for example. So it can be useful to suggest it if you have that thought in your mind of a pathology that may be better seen on contrast. There's nothing wrong with suggesting it, but generally we'll protocol it with contrast if we require it. Yeah.
Sure. So everyone who's been watching, you should all get feedback links emailed through to you within the next 5-10 minutes or so. But I'll also paste it into the chat box below. So let me just do that now. So once you fill in the feedback, you should get a certificate sent to your email. So next Wednesday evening at 8 PM, so that'll be this time next week, Dr. Murari will be presenting a structured approach, common cases and pitfalls of chest X-ray interpretations. The link to register for that is in the chat box. It's the middle one, and that'll go to the medal event for that. So don't forget to sign up for that so you don't miss out. And that last link will take you to the Mind the Bleep website, where you can sign up for all the radiology webinars, and then you'll just need to put in your email, and then you'll get notifications of when to attend those. There's been a few people asking for the slides and if it's recorded. So this does get recorded. It just needs to be downloaded from Medal because they're quite long presentations. They take quite a long time to download, but they will be uploaded to the Mind the Bleep website in the near future. Just while I've been talking, Sam, there's one last question. What information do you get from the doctor when requesting a scan?
Yeah, so that's a good question. A useful thing to know is the side. If there's any neurology, it very helpfully would help to guide our approach to the scan interpretation. Obviously, we look at everything, but obviously it can guide and influence our focus if we know what particular side there's neurology on. The duration of the symptoms is also useful. The actual neurology findings, because obviously the thing about brain imaging is it's all functional anatomy, which can be correlated to a specific localized area often. So if we have a good neurology exam, specific findings can actually help to direct our interpretive approach to that. So any particular neurology, the side of the pathology, duration, any particular past medical history. So obviously if they've got a history of cancer, that's quite important to let us know about, for example, any previous strokes, for example. So good medical history is also important.
We'll give it 30 seconds just in case anyone has any last minute burning questions. Just again, don't forget to fill in the feedback. That's all the links that you need to do next are just above in the chat box. So the feedback for this session, that's how you'll get your certificates. Next week's chest x-ray webinar link is also up there, so don't forget to sign up to that. And also how to sign up to all the other webinars that MindTheBleep does as well. All right. I think that's all the questions. Thanks so much, Sam.
Okay, no problem.
All right. Take care.
Thanks a lot. Bye.